Welcome, everyone, to our monthly seminar on spirituality and health. And today we have a wonderful speaker, Dr. Camelia Adams from the University of Saskatchewan. And Dr. Adams got her MD from a university in Romania, and then a Master of Science degree in Neuroscience from the University of Western Ontario. She completed her psychiatry residency at the University of Saskatchewan, followed by a fellowship in mood and anxiety disorders at the University of Toronto. Since joining the faculty in the Department of Psychiatry at the University of Saskatchewan in 2011, Dr. Adams has built an academic career that blends research, teaching, and clinical practice with the focus on anxiety, mood, and trauma-related disorders. Dr. Adams is a professor in the Department of Psychiatry, University of Saskatchewan. Over the past decade, she has authored over 30 publications in the areas of mood, anxiety, and trauma-related disorders. She combines psychopharmacology with cognitive behavioral therapy and interpersonal group therapy to provide comprehensive care. Dr. Adams is the recipient of numerous federal, provincial, as well as local funding support for the research that she is doing. She's also a very close friend and colleague, so I would like to introduce you to Camelia Adams. So Camelia, take over here.
Thank you so much, Dr. Koenig, for the kind invitation. Over the years, I've attended many of these seminars. I've been so impressed with the quality and depth of the presentation. So for me, it's truly an honor to be here today and to share some of the research we've done together and some of the reflections. But I also want to say that I look forward to the comments and feedback from everyone in the audience, since this research in itself is a bit unique and quite new. I'll explain later why. So I'm going to try to share the screen. I have a curved screen, so I always worry that people can see very well, but you let me know. Can you see this?
Yes, we can see it. Looks great.
Okay, excellent. So specifically my talk today will argue for the importance of the concept of faith maturity as a distinct construct, probably from religiosity, which is more commonly used in mental health research. And I will try to present the perspective that highlights the unique value of conceptualizing a faith along a continuum of maturity, rather than the binary framework of religious versus non-religious. But because I am a clinician, probably I'm going to focus very much on the relevance for mental health and for clinical care. In order to do this, I have a brief agenda. I'm going to try to review a little bit of the historical context and probably emphasize Canadian perspective, glimpse at a few clinical cases, and try to build a case for faith maturity. Then I want to present you the data on a study that we recently completed, and the paper just got accepted recently. Is a study on a clinical sample from patients recruited here at IUH in Saskatchewan. And then I will explore some of the implications and hopefully have an interesting open conversation about it. Now, before I dive into the research, I just wanted to show you a few images of some paintings, my paintings. I think in addition to psychiatry, I do have a deep passion for art. And I do believe that art holds probably profound healing properties and a spiritual dimension that sometimes transcends scientific language. And I think because of that, occasionally throughout the presentation today, I'm going to invite you to rest your eye for a few seconds on some of the paintings and just make sure that we activate both hemispheres and stay engaged. So this is actually a painting I've done based on an image in our backyard in the summer. And this is a painting of our backyard in the winter. Not as pleasant given the low Canadian temperature for very many months, but I would say equally beautiful. So to really dive into the relationship between religion, spirituality, and mental health, I think we need to look back historically. And as Dr. Koenig has pointed out in many of his writings, we have to remember not just the bad, but also the good. And, you know, just going back centuries, maybe 1,000 years ago, we will remember that the first hospitals were built by religious orders, that the first physicians were actually part of clergy, and the religious orders were actually the ones licensing physicians, that the first mental hospitals, and Mary of Bethlehem was built by religious orders, and later on the moral treatment was developed by Quaker William Tuke, and later on just informing the development of asylums in England and US. But, you know, apart from that, if we think about all the humanitarian efforts around the world, the benefits of AA, and moving outside of Christianity, the benefits of the generosity of other religious traditions, for instance, the soup kitchen in the Sikh traditions that, you know, if you read articles, they fed, you know, lots of people through the pandemic without asking for anything. Anybody who needed a meal was served. So this is what we probably forget, but what we remember often is the bad and the ugly. The Inquisition, the religiously motivated wars, the religious terrorism, the clergy sexual abuse, and, you know, something here in Canada that hits home is the residential schools and some of the atrocities that happened there. So in bringing this together, we have to remember the impact of spirituality and religion and some of these views on mental health and psychiatry. And if we only look at the father of psychoanalysis, Sigmund Freud, the Austrian physician, we remember that he had a huge impact on psychiatry, given his negative views on religion, which was seen as illusion and wish fulfillment, collective neurosis and hindrance to rationality. He published numerous books about it that really had a significant impact. But we also have to remember that even Freud had positive views that were probably minimized. And he did see that religion can offer moral and social cohesion, psychological comfort, and cultural and artistic inspiration. Another fear that I grew up with, because I grew up in communist Romania, and my father used to talk about Marx and Engels. So the philosopher and political theorist Karl Marx, that actually was the author of the Communist Manifesto, and he's famous for coining religion the opium of the people. Just a sentence before he said that, he also said that religion is the heart of a heartless world and the soul of soulless conditions. I guess what I'm trying to say is even some of the more influential people in our history regarded religious as a complex phenomenon with both positive and negative aspects. And I think in bringing that thinking forward, I want us to start to think of those layers of stages of faith maturity. Coming back to Canada and more modern times, I just want to introduce you to the Canadian Psychiatric Association position statement that was actually authored. The first author was Dr. Gary Chamovitz, who was actually a forensic psychiatrist, more focused on the legal aspects. I don't think he has done research on religious and spirituality, but he was very a leader in creating this position statement. And I just want to read the title and the conclusion for you. The title was Freedom of and from Religion. And the conclusion was that we believe that psychiatric care, while sensitive to the spiritual, religious, and cultural needs of the patient, needs to be provided in a secular fashion, attending to the best and most appropriate needs of the individual. So in a way, is so complicated, it's so controversial. We have to be careful because Canada is a multicultural landscape. So better stay away from it, kind of throw the baby out with the bathwater. Now, luckily, the World Psychiatric Association 2 years later in 2016 published also a position statement led by Professor Moreira Almeida, Brazilian psychiatrist, who I would say was able to outline 7 principles that are more, I would say, more wholesome, wiser invitation to psychiatric care to actually pay attention to the needs of our patients and do this carefully and well informed. So I will go through this briefly. A tactful consideration of patients' religious beliefs and practices, as well as their spirituality, should routinely be considered and will sometimes be an essential component of psychiatric history taking. An understanding of religion and spirituality and their relationship to the diagnosis, etiology, and treatment of psychiatric disorders should be considered an essential component. There is need for more research on both religion and spirituality and psychiatry, especially on their clinical applications, and this study should cover a wide diversity of cultural and geographic backgrounds. Psychiatry should be expected always to respect and be sensitive to the spiritual religious beliefs and practices of their patients and families and carers of their patients. Psychiatrists, whatever their personal beliefs, should be willing to work with leaders, members of faith communities, chaplains, pastoral workers, others in the community support of well-being in their patients. Psychiatry should demonstrate awareness, respect, and sensitivity to the important part of spirituality and religion play. And psychiatrists should be knowledgeable concerning the potential for both benefit and harm of religious, spiritual, and secular worldviews and practices, and be willing to share this information in a critical but impartial way with the wider community in support of the promotion of health and well-being. And I think this, 7th point in a way supports what we are trying to do today here. Now, luckily, the CANMAT guidelines, the Canadian guidelines for mood and anxiety disorder. So these are the most recent guidelines for depression I was lucky to be a part of. They got published in 2023. And they are recognizing finally slightly the importance of religious practices and religiously informed treatments. And now we recommend cultural and religious adaptations of evidence-based psychotherapies where available and appropriate based on their demonstrated efficacy across various cultural and religious groups. So things are shifting, they are changing, but again, history kind of goes back and cycles, and sometimes we deny everything and then we try to rescue it back. So what does this all mean? And what are we supposed to do? Clinical care and taking care, not just of our patients for psychiatric needs, but also for spiritual needs. So what should we do? I think we should pay attention to a couple more paintings. Start with a painting I've done based on a photo we took in Rome, this timeless ancient city. You can see some of the ruins and the wonderful umbrella-like pines. You can almost hear the cicadas in the air. And then a painting based on, it was actually a plein air sketch I've done when we were visiting Waskesiu here north of Saskatchewan, and just stopped the car to take photos and decided to stay and do a sketch. And trying to figure out what we need to do and how we should think about this, we always have to remember the people. And again, as Dr. Koenig and his colleagues have wonderfully outlined, 84% of the world is still religiously affiliated. 68% of unaffiliated individuals still believe in a higher power. More than 80% of individuals with mental health disorders use spiritual coping. These are data from USA. And individuals generally, when they suffer from mental health illness, they seek clergy more than they seek people like us, so mental health professionals. And some of the research that even a colleague of ours here, Dr. Bates, published about 10 years ago, show that most patients want to discuss spirituality in their appointments with psychiatrists. However, psychiatrists want it less than their patients, unfortunately. Just going back to the obvious that I'm only going to briefly summarize many of the findings that show that overall there are beneficial effects on mental health, on religious and spiritual practices. So all-cause mortality, depression, anxiety, alcohol and substance abuse, suicide prevention, personality traits, hope, optimism, self-esteem, meaning and life satisfaction, marital and family functioning, and better adjustment to clinical concerns. So overall, there are mental health and health benefits and reduce mortality when people engage in religious practices. There are, however, some negative effects noted, generally related to negative religious coping or spiritual struggles in therapy, and sometimes some specific psychiatric conditions such as bipolar disorder or schizophrenia seem to be more sensitive. So we have to keep this in mind, because today our studies focus on depression and suicide. I will not dive into all the literature referring to other aspects, but kind of keep it focused on depression, suicidality. So some of the most significant studies in terms of prospective longitudinal studies with a large sample of participants is the nurses studies led by Professor Vanderwill from Harvard University, who show that in nurses who attended religious service at least once a week, there was a 5-fold lower suicide rate. Yet, you know, the literature, probably Dr. Koenig can confirm this, shows that one of the most strongest determinants of health and mental health is church attendance or religious practices. Is also probably one of the easiest to study, and yet is not always that clear cut. In a recent review by Bram and Koenig, 152 prospective studies from all over the world were analyzed. And of course, the measures varied from religious attendance to religious spiritual importance, coping, religious denomination, and the emphasis was placed differently. But yet is important to notice that 49% showed a significant improvement related to depression, 41% showed no association, and 10% had more depression or mixed results. I think I want to mention another study. I think Professor Williams from Harvard mentioned it. I looked into it. So the idea that attending church is very good for your health is very good for your health when it's done for the right reasons. And I think the way they looked in this study, they tried to figure out all the mediators of the relationship between church attendance and health. And what they found that in people who attended primarily motivated by social reasons, like wanting to be accepted by the community, and this was kind of the main motivator, they sometimes develop more depression because they probably met with the, some of the criticisms and judgment of the congregation, which they were very sensitive to. However, in those that were motivated by a meaning and a desire to connect with the divine, so which they called spiritual attendance, marked by statements such as my faith is renewed, or I feel the presence of God, I feel inner peace. This seemed to be the most powerful predictor of their benefit on depression. So I think the way I think about it, but again, I welcome everyone and to share with me your insights about this. Probably most people who go to church frequently learn a lot and develop a mature faith, but probably we can compare it to, I personally think about religious practices similar to going to school. So a lot of people go to school regularly for many years, and you can say the more they do it, the more educated they get. Yet that understanding and depth is not the same in everyone. And while some people who go to school can be Nobel laureates, we can also have people who go to school who end up being the school shooter. And Ted Bundy was a lawyer. So in a way, I think it's always going to church frequently tells a lot, but also if we want to look into layers of depth, probably the idea of faith maturity makes sense. Just assessing what is it that people truly understand and feel and what they're motivated by when they go to church. Some of the neuroimaging studies led by Dr. Lisa Miller from Columbia University kind of support something similar in the sense of the belief system seems to matter. So altruism and love of neighbor as self was associated with less depression of the 10 years, protection against depression for the next 8 years, increased cortical thickness, and also self-reported importance of religion and spirituality, but not frequency of attendance or denomination, was also associated with a thicker cortex and reduced depression by 90% over 10 years. Now, some of the criticism of the relationship between religion, spirituality, and health have been summarized nicely in a review, and saying that most of this research used on Christian comes from US. There are some problems with religious construct because it doesn't really capture the spiritual essence that would be kind of universal for most traditions. And there is a lack of exploration of multi-faith perspective. And I guess, is there any light at the end of the tunnel? Well, my painting says there is light at the end of the road. So I painted this painting was based on a photo we did while driving back from Calgary. My husband was driving, so I took the photo. And this one is another painting that I did based on a photo that I took. I was driving, but I did stop the car because there was a beautiful rainbow, and I took a photo of it. So if there is light at the end of the road, it might even be a rainbow. So in trying to put all these concepts together, the idea of the depth of understanding of faith, the meaning, the religious maturity, I was trying to figure out what would bring all this together. And a collaborator of mine from the Department of Religious Studies suggested that I look into James Fowler and his work on faith maturity. So James Fowler was an American theologian and Methodist minister, was also very interested in psychology. He was a professor at Emory University. And he read a lot about developmental psychology, Ericksonian stages, Piaget, and also moral development. I think he collaborated with Kohlberg. And he tried to integrate this into a theoretical model of theology, but also tried to ask empirical questions to validate it. And basically, what they did, they developed a very thorough interview, and over a span of about 10 years, they interviewed 356 people, somewhere there. And some of these people were interviewed at Emory University, Harvard. They collaborated with some from Toronto. And they kind of qualitatively assess, kind of analyze all these interviews, and they were able to come up with 6 stages of faith. So basically, they were these stages were basically dependent somewhat on the age. I mean, you kind of needed enough brain capacity to be able to graduate from one stage to the next, but also some people can get stuck at the same stage from adolescence till their old age without progressing further. So these are the stages: primal faith, stage 0, intuitive projective faith, mythic literal faith, synthetic conventional faith, individuative reflective faith, conjunctive faith, and universalizing faith. So I'm going to go through the description to kind of give you an idea. So the stage 0, primal faith, kind of characterized by hopefulness, was the stage that infants would develop in the first 2 years of age. This is kind of very much in keeping with attachment theories. Through their relationship with their caregiver, they develop this kind of trust. This is the stage that is in Erickson calls trust versus mistrust. If you are well taken care of and the caregiver has very attentive practices, then you develop trust and the sense of safety. And even though this cannot be articulated very well, at this stage, children feel loved, secure, and then they start to have a sense that everything is good and universe can be trusted. In stage 1, the intuitive projective faith is still a very egocentric stage between 3 and 7 years. The faith style is imaginative and fantasy filled. There are storages and images from family members or religion. They shape the understanding of God and the world. There is a sense of right and wrong, but is governed very much by reward and punishment. If you're a good kid, God gives you what you want. Faith is very concrete, is magical, is influenced by adults, and again, very egocentric, is about me. Stage 2, mythic literal, typically between the ages of 7 and 12, but some people can stay in this stage actually even later. So there is more capacity for abstraction, but there is still quite a literal belief in stories and moral rules. So good people are rewarded, that there is an understanding of cause and effect, there is an understanding of fairness and reciprocity. There are anthropomorphic images of God. God is the old man with beard who's very kind. And there is an overly literal interpretation of symbols. So like there is more access to symbols compared to the previous stage, but quite literal interpretations. Stage 3, called synthetic or conventional. So, the word conventional probably marks this stage. Is marked by interpersonal connectedness in the sense that, so it occurs in teens and it can continue through adulthood till old age. Some people stay at this stage. So it's very much can be described by conventional, conformist. It's submission to authority and the beliefs of one's group. Usually people identify with the institutions, whatever they're told in church and by their families. They don't examine if there are questions or conflicts that emerge. They don't dare to go there. They usually ignore those. So the faith tends to be unexamined. It kind of depends on what others tell them and search for approval for those respected figures. And again, some people stay at this stage. Now, stage 4, individuative or reflective faith, is a stage where usually occurs in adulthood. And I think in Fowler's sample, the highest sample was 20s to 30s. So people in 20s to 30s have the highest percentage of stage 4. So this is a stage where young people start to examine their faith. They start to wonder. They try to distinguish the truth from the cultural entrapments. So they reflect, they have personal reflections, the ownership of their own beliefs. They question their inherited beliefs, the authority. They move from what others say to what they truly believe. So it's a quest for truth. However, this is a tough stage because it may involve tension, doubt, angst. Some people can get stuck. I personally think this is the stage when people start to wonder the problem of pain. If God is so kind, why did he allow pain? So you often see people stuck at this stage. And in a search for truth, sometimes they don't find the answers. However, if they do move, and interestingly, I should say this before I forget, interestingly, Fowler found that in 20s and 30s, they start to question and search for truth. When they move to 30s, to 40s and 50s, they either moved further into a stage 5 or they went back to a stage 3. So even though that wasn't a longitudinal study, he kind of found a higher percentage of stage 3 in people in their 40s than in the 20s. So he kind of made that assumption. But if they do move in a stage 5, it's a conjunctive faith. Faith style, it gets complicated. It's a faith style allows for subtleties, for acceptance of paradox, of mystery, of diversity, integrates rational thought with intuitive wisdom. People start thinking beyond dichotomies. They realize truth is multidimensional, and they are characterized by openness and humility. And then the final stage that is actually very rare, Fowler had only one person out of 360. It's transcendent, all-encompassing compassion. Is a stage where seeing people see others as a community where everyone is important. It's embodied by figures like Gandhi, Martin Luther King Jr., Mother Teresa. People are motivated by love and justice beyond self-interest. And this is actually quite a very rare stage. I have some examples in my mind. I'm trying to imagine myself, apart from the documentaries I've seen about Gandhi's life and the desire to kind of find good for all. And I know even Gandhi has been debated by many. I mean, there are examples. I remember reading in the Book of Dead about the Tibetan monks when they were tortured by their Chinese invaders. And when they were asked later on, what were they fearing the most? Some of them said that they feared the moment when they lost empathy for their torturer. Or there is another story with Father Joseph Rea, who was a Melkite Catholic. I think he was very focused on advocating for the rights of less fortunate people. He was initially expelled from Egypt for advocating for the rights of women, and he moved to US. I think this was back in 50s. He befriended Martin Luther King Jr., started advocating for the rights of Black people, and at some point he was caught by Ku Klux Klan, and he was beat up, almost killed. And while they were beating him, they were saying, "You nigger lover." And he said, "It's true, but I love you too." So I think, to me, that these are kind of some of the examples of being able to love everyone, even those that are harder to love in a stage 6. So how do you capture that in research? How do you capture that? First, I'm going to say, how do you capture that clinically when you work with patients mental health disorders, and you try to understand them, and you try to understand how their stage of faith maturity might really impact their health. And I'm going to give you some examples. This first case, it's a real patient from my own practice, not the photo, of course, but it's based on a story. It's someone that I'm currently treated with trauma-focused cognitive behavioral therapy. And of course, I modify the data so it's not identifiable. So Melanie is a 16-year-old depressed high school student who comes to therapy after conflicts with her parents regarding religious disagreements. She was raised in a devout Christian community and believes strongly in the teachings she's being taught, but she admits that she mainly believes them because everyone I love does. In therapy, she confesses that she has been sexually abused by her own father between the ages of 5 and 11, often being told that disobeying her father means disobeying God. She struggles with guilt for not being able to absorb all the pain to keep the peace in the family, and for only going to church once a week. So this is one of those examples where people go to church once a week. But if I'm going to ask you, what do you think her faith maturity stage is? I'm not going to ask you what her father's faith maturity stage is, because this scale only has positive numbers. But I mean, according to Fowler, this would be more like a stage 3. That stage focus on belonging, listening to the institution, to the trusted adults, and shaping your image of God according to that without examining much. Now, another example, and again, I'm going to try to use kind of different religious traditions. Amrit is a 59-year-old Sikh woman working as a nurse for the past 30 years. She's known among her colleagues for her gentle smile, calm presence, and the way she hums hymns softly while charting or caring for patients. Recently, Amrit was diagnosed with stage 4 colon cancer with metastasis to the liver and lungs. She comes to psychiatric attention for a drop in mood following a large operation, removing a portion of her colon, as well as removing one lung due to metastasis. This is another patient of mine, actually. However, in the psychiatric office, she denies symptoms of depression and feels that her mood has recovered already. When asked how she feels about her prognosis, Amri replies, I see life and death as part of Waheguru's Hukam, divine order. My body is weak, but my spirit rests in God's will. The cancer is not my enemy, it is my teacher. It reminds me that I'm not in control, and that is strangely freeing. So this patient, again, with some other details, I had her in a therapy group for a year, and interestingly, she was going through cancer and she was operated multiple times. Colon was removed, a part of her liver was removed, one lung was removed. And then we had another patient in that group who got diagnosed with cancer. And the other patient was asking her, how can you be so serene in the face of all this pain and suffering? And she says, I don't carry it. I give it all to God. God carries it for me. So some of these, inspirational moments where faith gets to another level. So according to Fowler, this would be a stage 5. And then one more example, Miguel, a 65-year-old retired pastor and activist who dedicated his life to advocating for the poor. Even in retirement, he lives simply, gives away much of his pension to social causes. Despite personal losses, he radiates compassion and forgiveness, even towards those who wronged him. When discussing grief, he says, all life is interconnected. My friend isn't gone. He's part of the whole. His therapist observes that Miguel inspires others with his peace, humility, and radical commitment to justice and love without need for recognition. So according to Fowler, this would be a stage 6. So this is kind of moving into that universalizing phase of caring about everyone as themselves. So with all these examples, in trying to do research to see would this make a difference, I can tell you that when I search for research on faith maturity, I only found one study that was done in the general population and basically looked at faith maturity and well-being. And yes, there was a positive association. However, I wanted to see if faith maturity would be relevant for our patients. And I found one scale, and I remember when I found the scale, I emailed Dr. Koenig years ago. I don't know if Dr. Koenig remembers, and asked him, Dr. Koenig, you know about all the scales. What do you think of this one? So he answered briefly, I like it. And I think that was all I needed to to know to be able to use it in a study. And I'm going to read this scale to you. I'm not saying it's able to capture everything, but it captures something. So the scale was originally longer, developed by Benson and colleagues, but it was more focused on Christian communities. Some of the questions were referring to Jesus, and then Piedmont modified it, they shortened it. They replaced the question from Jesus with the God of my understanding. And then research showed that it was quite reliable, valid, and used in a variety of faith tradition just to kind of to be validated. So these are the questions. I help others with their religious questions and struggles. I seek out opportunities to help me grow spiritually. I feel a deep sense of responsibility for reducing pain and suffering in the world. I have significant portions of my time and money to help other people. I feel God's presence in my relationship with other people. My life is filled with meaning and purpose. I care a great deal about reducing poverty in my country. Sorry. I try to apply my faith to political and social issues. My life is committed to the God of my understanding. I talk with other people about my faith. I have a real sense that God is guiding me. I'm spiritually moved by the beauty of God's creation. Anyway, they omitted item 6 from the scoring based on their analysis. So basically, what this scale was meant to measure is the degree to which a person embodies the priorities, commitments, and perspective characteristic of a vibrant and life-transforming faith. So that motivation and meaning that I was talking about earlier. And in the way the scale is scored, it has actually two subscales, a horizontal subscale. So the questions focus on relationship to others. So basically, the horizontal scale refers to very much to the commitment to others, and the vertical subscale closeness to God, so one's connection with the divine. And even though it is not useful just for Christian traditions alone, it's probably limited to monotheistic traditions. Even though I think some people said even in some of the in Hindu tradition, it can be seen as a polytheistic traditions, but they say that even Hindus can be monotheistic since they have a primary figure, a primary god overseeing the rest. So just to describe our study, we recruited participants from people referred for our tertiary care center, so psychiatric assessment. I convinced 7 psychiatrists, my colleagues, outpatient psychiatrists, to send the initial questionnaire to their patients before they were seen in the clinic and diagnosed. And we developed this questionnaire in a red cap, a link that can be sent, and then patients would complete it and it would kind of get imported into a database. Of course, we got informed consent. We collected a bunch of variables for depression, anxiety, social phobia, suicidal behavior questionnaire, the faith maturity that I just showed you, and also well-being. If you think about well-being as everything that goes well from a mental health perspective, the symptom scales basically capture everything that goes wrong, right, from a mental health perspective. So over 5 years, we had about 224 entries. And of those, even though they completed the scale, only 174 consented to have their data used for research. From those 174, 24 were excluded because maybe the data wasn't completed enough. And then our analysis, when we examine our questions, kind of the sample range from 114 to 142 based on the scale completion. Briefly, I'm just going to show you if you want to kind of see the characteristics of the sample. So the first graph in the left upper corner is basically a histogram of the age distribution. People were kind of, somewhere between 20 to 70s with a higher percentage of people in their 20s and 30s. We did have a higher sample of females, almost double than male. In terms of the way they self-rated their mental health, you see the majority of the sample described their health as fair or poor, which kind of makes sense. However, their general health was rather very good or very good. So it was mostly mental health that was the problem. Now, in the first analysis, we looked at the association, or in what ways faith maturity predicted our outcomes. So in the first plot, if you look in the left upper corner, you can see that as faith maturity dropped, so that kind of blue line is going down, the depression score increased. So the lower the faith maturity, the higher the depression. These were all statistically significant associations. When you look in the left lower corner, you see that as faith maturity dropped, suicidality also increased. And also in the right lower corner, you see that as faith maturity increased, well-being also increased. And again, these were all highly significant associations. Now, I had the help of a statistician who did some very complex analysis. And then when we later looked at the subscale, so that faith maturity vertical scale, so the connection with God, we found that the higher that vertical dimension, less depression, less anxiety, lower suicidal risk, and greater well-being. However, when we looked at the horizontal scale, the connection with others, love your neighbor as thyself, we found that higher faith maturity was only linked to greater well-being. So in a summary, vertical, so the connection with one's deity benefits mental health and well-being, while the horizontal, the connection with others, mainly supports well-being. Now, my statistician colleague went ahead and did a multiple regression with covariates, where basically we look to see if there are any other reasons that can explain some of these associations. And interestingly, what we found is that when depression is included in the analysis, the link between faith maturity and suicidal behavior disappears. Depression remains a strong predictor of suicidal behavior even after controlling for faith maturity. So how does this look like? This looks like this. So faith maturity, when faith maturity increases, suicide decreases. When faith maturity increases, depression decreases. However, obviously, we know that depression and suicide are connected. And when we look at that association, the relationship between phase maturity and suicide disappears. And the analysis was actually to clarify, it was a mediation analysis where we looked if this can be partly explained through the effect of depression. And indeed, we found that phase maturity does decrease suicide, but is not direct, is partly mediated through depression. So because phase maturity decreases the risk for depression, the risk for suicide also decreases. I mean, this can be open for a lot of interpretation. I'm curious what you make of it. I would say that probably this also shows that it's not just, people don't commit suicide because they are afraid of the repercussions that come with, their religious beliefs. It has to do more with the understanding and the psychological well-being that they develop, and therefore less depression. That's kind of how I think about it. Is the effect is not direct, but it plays a big role into the psychological underpinnings. So to summarize our results, this is the first study, the first clinical study to my knowledge that shows that phase maturity plays a role in mental health and well-being of patients with psychiatric disorders. Phase maturity, we found that it does impact depression, which in turn impacts suicide. The vertical component relationship with the divine is relevant for both mental health and well-being. And the horizontal component relationship with the world is more relevant for well-being. We do have to acknowledge some limitations because it was a sample size, a small sample size, particularly for men. Phase maturity scale is relatively new. It can be debated if it's good or not. It's not that recognized. It was a heterogeneous sample of people with mental health disorders, kind of a mixture of depression, some anxiety. And of course, we only included the consenting participants. This is one of the last paintings I'm going to show you. It's based on a photo of a waterfall in the Rockies. And just kind of the global conclusion that I'm trying to make is that religion and spirituality will continue to exist and color our worldviews and our health. And I do strongly believe that psychiatric care should consider the clinical impact of religion and spirituality, and psychiatric education should consider improving psychiatrist literacy in religion and spirituality. But I also think that psychiatric research should search for answers with better measures. Phase maturity might offer an opportunity, but kind of look at more layers, not just the behavioral aspects of religion, but also kind of the cognitive, the deeper emotional aspects. And hopefully we'll have more international studies, more religious traditions, and more interdisciplinary work between psychiatrists, theologians, psychologists, clergy. And I do want to acknowledge the people that helped me with this study. Miriam, she's our research facilitator, an excellent collaborator and friend. My husband, who tolerates all my questions about God and the universe and research. Don D'Souza, psychiatrist, who contributed many participants to our study. My PhD student, Samantha Carley, who's continuing this research in her PhD. Lloyd Balbuena, a great statistician and colleague. And Dr. Koenig, who answered most of my questions within 10 minutes because I think he's always in front of the computer. So thank you very much, and I welcome your questions. I do want to give my email for those of you who are interested in this project. We just happily found out that it got accepted in Brain, Religion, and Behavior Journal. And as soon as it gets in print, I'm happy to email it to any of you.
Camelia, Wonderful presentation. Wonderful presentation. My gosh. Okay, let's open it up for questions. We have about 6 minutes for anyone who would like to ask Camelia about the work that she presented and this topic. So feel free to unmute yourself and ask your question.
Hi, can you hear me?
Yes, Leonard, go ahead.
I'm just going to ask a brief question. I am speaking from Africa, and we have a problem with the whole issue of all the research being done with a understanding that people have a God-driven belief system. African people are primarily animistic. They have adopted a Western monotheistic belief system, but they are essentially, when you go to a funeral, you'll see that it's mainly animistic in their beliefs. Are there any studies looking at the health of meditation and in people who don't hold a God-founded belief system? Any work being done in that area?
So I haven't done any work in that area, but there are plenty of studies looking at the benefit of mindful meditation in mental health. I mean, in North America, mindfulness and meditation have been spread largely by Dr. Joan Kabat-Zinn, and I mean, a lot of research has been done on this, looking at the benefits that are not necessarily, related to religiosity or a certain belief system. It's more practices of quieting the mind, being present in the moment, non-judgmentally. Yes, and I mean, there are plenty of psychotherapies developed, mindfulness, meditation, mindfulness-based CBT. So this is a very broad area that can be beneficial for people from any tradition for sure, but it's not gonna connect them with their sense of divine. It's gonna connect them with some practices that come from there are spiritual practices primarily inspired from Asian philosophies, but they can be operationalized in a way that can be used by anyone for health benefits.
Fantastic. Thank you very much. Appreciate that.
You're welcome.
There is a question. Okay, Sarah, go ahead.
Hi, thank you. Hopefully I'll get this across quickly. I wrote down depression remains a strong prediction for suicide despite having mature faith. I hope I have that right. And then I know you showed the horizontal connection. I guess when I'm trying to think, I'm a faith community nurse, and I know people have a spiritual battle going on sometimes too. But my question is, do you think that the disease, the depressive disease, maybe the state somebody's in, despite being very spiritually mature, may just be so desperate at a certain point or moment that they lose that spiritual battle? That's kind of my question. Maybe I'm looking for reassurance too. I don't know.
Sorry, did I interrupt you?
No.
Yes, I highly believe that. In fact, what I mean, it's even recognized if you in DSM, if you remember DSM-4, who used to have axial diagnosis, we would say that during illness people regress. So if someone is ill, you don't diagnose the axis to you don't diagnose a personality disorder, because people might regress, return to more immature ways of coping and personality traits, but is mere the impact of illness. And it's true, like sometimes you see that regression when people get very sick. I mean, there is a whole biology, like the hippocampus is shrinking is not just a joke. So obviously it's going to be reflected in the clinical presentations, and people would have less access to their mature faith. And so I do think it's a bit of a bidirectional effect, but in the same way. So the depression is a strong predictor of suicide, but we also found that faith maturity protects against that depression. Now, I can't tell you if that means they can it protect entirely if someone cultivates enough faith maturity, you know, and then develops a way of living that nurtures that constantly. Yes, we know that depression can occur when multitude of risk factors accumulate, and maybe everybody has a breaking point, as we've seen in trauma-related studies. But definitely there is a bidirectional relationship there.
Thank you.
Very good. Well, we are at 1 o'clock, and I want to thank Camelia for a wonderful presentation, and thank you all for your questions and also for your participation today. And we will see you next month for our seminar. So everyone have a good week and take care. And thank you again, Camelia, for all of your work putting this together.
Thank you so much, Dr. Koenig, and everyone. Thank you.
Bye-bye.